is Michael Hall, and I wanted to go over Change Agent. This is my video. The thing I wanted to discuss is falls in the hospital. The older population is not getting up as much, and when they do, they're not being safely moved throughout the hospital, and it puts them in danger and it puts them at a risk. It should be one of the least places for a fall to occur, but happens quite often. And we've had traumatic falls, where people have been severely injured. So that's what I wanted to focus on today. That's where I want to be a change agent in my society, in my community, because it's where I work at. One day my dad may be in there, or even I will be in there, and I want to be able to provide the best care possible. So like I said, the biggest thing is the increased falls in the hospital. The average age is around 63 years old. 10 falls in the past month, that's like kind of like a common thing in our hospital. That's what just recently happened. We had 10 falls. So falls in the United States hospital averages from 3.3 to 11 falls per 1,000 patient days. At our hospital, it looks at it is if we have 3 falls, 3 falls per month, that is considered high. And then we had 10. So in our hospital, what they do is they have a discussion, just a fall prevention, and then we try to come up with different ways and different ideas to prevent people from falling. So the biggest things, like the questions I was starting to ask is, are the falls occurring from the staff or the lack of oversight? It's becoming, it's both. It's the lack of oversight because we're so run shortly staffed, but we're also it's from the staff members not being able to move patients. And then if the team was to learn from occupational therapists on total knee transfers, would the falls decrease? And the answer is yes. Next thing is like the input. What resources do we have? Well, we have nurse managers, we have nurses, nurses assistants, which is CNAs. We have a rehab director, occupational therapist, a CODA for me. BMAT, which is a bedside mobility assessment tool. And then we also have supplies. I've been working diligently to have walkers, and then now we have walkers in every single room. And the activities is assessing if the client is appropriate for transfer. BMAT, which is the bedside mobility assessment tool, is an assessment tool for nurses to use to see if a person is able on the bedside commode. What are they able to do? And then through that scoring gives you a number system. And so when a nurse comes in or a CNA comes in, they have a little board on the wall and everything. They have a number written where it has the assessment, and then they'll see like a 3 or 2 or 1. 4 being the highest, so they don't really need assistance at all. And then the patient or the nurse or CNA automatically knows what it is. They run in the room, they're like, okay, I see so and so is a 3. I can get them up and get them in the bedside commode, and which is good because I've seen so many times where handoffs, a lot of that stuff is being missed. We have like safety protocols as well. We also have identifiers to know if a patient is considered a high fall risk or not. As we give a person like a yellow gown or a yellow brace that says fall risk. Anyways, but once they're in that chair, how do we keep them from falling? So one thing that I've been working on, chair alarm. The chair alarms that we used to have used to be a clip, and then now we have a sensor pad. Whenever a person gets off the pad, the alarm goes off. They sit back down, the pad turns off. And then not only that, is connected to the wall so that the nurse knows what room the patient is coming from. Another solution that we've been kind of working on is cameras in the room and everything. These cameras are HIPAA approved, but they're the watch, consider high fall risk. We're going through detox. We'll have a camera in there so sometimes they're just not in the right mind and everything. That is another way to prevent a person from falling. So we have all these different resources, but then what do we do with it? So I'd set up classes where I would meet with them. Just at the beginning when we were setting up the BMAT, which is the bedside mobility assessment tool, I would make sure that all the nurses and CNAs were familiar with how to use the lifting equipment and then how to get a person up out of the bed safely. I also show them how to use the lift. But not only did I show them how to use the lift, I let them experience what the lift feels like. So when they are lifting a person up, they know what it feels like. If they're having like a rug burn and everything, because some of the Hoyer lifts and everything, I explained to them, I was like, hey, you have clothes on now. So imagine when you don't have clothes on. That's like, that right there can really hurt somebody, can cut someone. Educate them where to get the batteries for the lifts, where all the supplies are, where the lift slings are, so it can reduce the time down. Because a lot of what the nurses would complain about is that it takes too long. And then I would set up a timer and everything. I would set up whatever the floor I was on. I said, okay, I want to go grab all the supplies. I want you to time me. And most of the time I can get all the supplies, get the lift, and everything done within less than 5 minutes. We got to start using lifts to get the people up off the floor. I said it's also going to reduce, you getting injured, but then also the severity of the injury for the patient as well too. So, like I put on there, train the nurses as CNAs on the floors, show them how to use the lifts correctly, know who is considered a fall risk, so making sure that we're doing the patient identifiers, and then making sure that they know how to assess the BMAT successfully, so they can understand that. Every room, we need to make sure that they have rolling walkers or the right equipment to transfer a person to. If we're using bedside commodes, make sure the bedside commodes are not rusted or whatnot. So in the midterm outcomes, is just being able to have nurses and CNAs train each other. I need to be able to take a step back and making sure that the clients are being able to get up and out of the bed using the right techniques and equipment, and then making sure they're using the proper equipment as well too. Just like when it comes to easy stands and easy lifts, we don't need to be just using a Hoyer lift for every single one. When a person can actually stand up, they can use a walker, and making sure that everybody's using the whiteboard. Determine what actually the assistance level is. Make sure when that person leaves and everything, make sure housekeeping's cleaning that whiteboard off and make sure that it does not have a correlation from the last patient to this patient, so we don't make mistakes and everything. And then the long-term outcome is to be able to train nurses and CNAs, and that's what actually I've been trying to talk to with the educator, is being able to educate during the orientation. So when they come right out of orientation, we're educating the nurses, the CNAs, the people that do transport, and then my hope is that the fall prevention will decrease from safe transfers. And then that occupational therapists and nurse managers will have a fall meeting to analyze every current fall, which we're kind of doing something similar to that right now. So my hope is that the monthly falls will reduce, and then the length of stay will decrease as well too. That's what I'm trying to say. And it shows is when we get people up and we get them moving, we prevent them from getting worse off while they're in the hospital. Because sometimes when they're in the hospital, they don't get up, they don't get moving. And then what it does is it increases their length of stay, which also increases their chances of fall and then risk of infections and other nosocomial infections. We just don't want that. So if we can educate our team and make a change and everything, I think that we can make a difference. And my big over outcome is hopefully that this program and what we're doing right now, and even the therapists up to come, will also be able to do these kind of things too. So it's just not just this little one small town. I hope it becomes bigger and bigger and bigger and become like a ripple effect where it affects our whole health system, where CNAs and nurses are all getting people up in a timely manner. We're preventing bed sores, we're preventing injuries, we're preventing falls. So that's my hope, and that's how I'm hoping to be a change agent. Thank you.